You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 9th, 2018. This week, the ODYSSEY Outcomes trial is just published. Bradycardia guidelines, atrial fibrillation in athletes, echocardiography, and of course, an American Heart Association meeting preview. First up is ODYSSEY Outcomes. And it's just in time for the AHA meeting that the New England Journal of Medicine has published a study of alirocumab versus placebo in almost 19,000 patients who had had previous ACS or acute coronary syndrome, elevated LDLs or ApoB levels. The dose of the drug was adjusted in blinded fashion to target an LDL of 25 to 50, and remember that the authors didn't let the LDL go below 15, so they adjusted it. The primary endpoint was CAD death, non-fatal MI, stroke, and unstable angina requiring hospital admission. The duration of the trial was just under 3 years on average, and the primary endpoint occurred in 9.5% of the active group and 11.1% of the control group. The hazard ratio is 0.85, and the absolute risk reduction is 1.6%. Now, components of the primary endpoint were as follows. Death from coronary artery disease was essentially not different. Non-fatal MI was 1% different, stroke 0.4% less, and unstable angina requiring hospital admission about the same as well. The death from any cause was well down in the hierarchical order of testing, and this was 0.6% lower. And I am pretty sure that alirocumab will not get a all-cause death reduction label. Now, when the authors put the groups of patients on the drug into 3 groups based on LDL levels, they found that the greatest risk reduction of the primary endpoint occurred in those with elevated LDL greater than 100. There's going to be a cholesterol treatment guidelines released at AHA, and you can be sure that there'll be more discussion on the clinical translation of the ODYSSEY Outcomes trial during that debate. Next up is bradycardia guidelines. Now, one of the most common consults the EP and cardiology service gets is for bradycardia. And despite the fact that the human species has been on Earth and been Earth's most dominant species for eons, people just think that the heart is going to up and stop when it gets slow. My friends, I'm here to tell you that the heart is very resilient. It just doesn't up and stop very often. Now, of course, the one caveat to the heart will not stop rule is that if a doctor, like an EP or surgeon, is involved, well then the heart is more apt to stop. So a group of authors from ACC and AHA and HRS have got together and they've produced a massive new document on bradycardia disorders. Megan Brooks has an excellent recap and news coverage, and I've highlighted some key points. First, sleep-disordered breathing is a common cause of nocturnal bradycardia, and the treatment is not a pacemaker, but to treat the sleep-disordered problem. Point number 4 is the most important, and this is in sinus node dysfunction, there is no established minimum heart rate or pause for which a pacer is indicated. No established minimum heart rate. What you have to do is you have to correlate symptoms with the bradycardia, and this is very, very important. His bundle pacing gets a mention in these guidelines. For those with an ejection fraction of 36 to 50%, and AV block, or who are going to pace 40% at the time, the authors say that his bundle pacing or CRT are preferred to RV pacing so as to prevent pacing-induced cardiomyopathy. Now, I'm a huge advocate of his bundle pacing. I love it. It's beautiful, but of course, I'm also an advocate for it to be studied in an RCT so that we don't fool ourselves and think it's better than it is. Shared decision-making also gets a strong recommendations. Good on the authors, I say, for making it clear that patients or their surrogates have the right to refuse pacing. And this latter point comes up more than you think. We see it when very ill, older patients, usually with dementia, present from the nursing home with AV block. Now, it's harder to have the discussion about not doing the pacemaker, but it's often the right thing to do based on the fact that perhaps the patient didn't want it in the first place, or perhaps the patient or the surrogates don't want to extend suffering at the end of life. Third topic today concerns atrial fibrillation in athletes. JAMA Cardiology published a nice study from Spanish authors concerning arrhythmia in young athletes. Now, these studies catch my eye since I co-wrote a book on this topic called The Haywire Heart. I did the evidence reviews and the medical chapters in that book. One of the key features of atrial fibrillation in athletes has been that most of the epidemiologic studies look at older athletes with long histories of training and racing. These are decades long. The most commonly cited meta-analysis is from Abdullah et al., and they find an association of athletics and AFib of 2 to 7-fold times greater than in normal controls. This most recent study from JAMA Cardiology is different for a couple reasons. One, it had 35% of women, and that's different because most of the previous studies had included mostly men. And the second big difference is that these were very much a younger group, the average age 22. So much younger than the previous studies. The Spanish authors looked at 7,000 athletes followed between 1997 and 2017, and they found only 21 athletes, 0.3%, had atrial fibrillation during this period. As you'd guess, most of the AFib was paroxysmal. And also, as you guessed, in multivariate analysis, the typical predictors were advanced age, number of years of competition, and left atrial size, all predicted greater chances of having AFib. I think the take-home point from this study is that AF is not really a young athlete's issue. It likely takes time for the structural changes to produce the left atrial milieu that's suitable for atrial fibrillation. Next topic is on echocardiography. My colleague, Dr. Melissa Walton-Shirley, has a great piece on the problems with echo in the real world. And newsflash, there are problems with echo out here in the real world. I note this piece because it's really well written, and she got comments from one of my old teachers, Harvey Feigenbaum, who has a beautiful quote on one of cardiology's biggest unseen errors, that is the left ventricular ejection fraction. Feigenbaum warned that the, quote, left ventricular systolic ejection fraction is one of the most overrated concepts out there, and he noted that diastolic or systolic heart failure cannot be diagnosed on echo alone because, sit down for this, because we don't treat measurements, we treat patients. I'd like to tweet that about 1,000 times. Take a look at MWS's piece and the cases that she presents in there. And a final pro tip I've learned from years of doing this is always look at your own echo. The report is okay, but look at the images. A, you'll be able to keep up your skills. B, you'll find that seeing the images in the context of your patient is often helpful. And finally, you may pick up faulty readings. So the next topic and final topic is an AHA preview. We have 2 stories on that. I did a piece on that, and there's also Patrice Wendling has a news story. So first thing at AHA that's going to happen is vitamin D is going to get another look. The VITAL study is going to look at vitamin D in primary prevention for the prevention of cancer events and heart disease events. And everybody knows that the preceding studies have really not shown any significant benefit. So this will be perhaps the final test of vitamin D as a health prevention tool. I think the bigger discussion, though, that day is going to be about the REDUCE-IT trial. REDUCE-IT is going to study more than 8,000 patients with elevated triglycerides and high cardiovascular risk who are already on statins, and they're going to get 4 grams of pure omega-3 EPA fish oil, brand name Vasepta, versus a mineral oil placebo. And the company, Amarin, has already put a press release out saying that there's about a 25% relative reduction in a composite endpoint. And the composite endpoint of major adverse cardio events is, for the most part, pretty solid endpoints. So these findings is also going to be an outlier because, again, previous fish oil studies have not shown benefit. And so we're going to have to figure out why is this study positive and the other studies negative. Possible reasons why REDUCE-IT is positive and other studies weren't include dosage. REDUCE-IT used a much higher dose of fish oil. The active arm in REDUCE IT also includes pure EPA. And the most important reason why this trial may be different is that the trialist included patients with high triglycerides in the trial. The third thing we're going to hear about at AHA that's big is inflammation. So canakinumab has been shown to reduce cardiovascular events in the CANTOS trial. That was last year, 2017. Well, now a different anti-inflammatory drug, methotrexate, is going to be tested in the CERT trial. And so this is going to be a big moment for cardiology, because if two different anti-inflammatory drugs show cardiovascular benefit, that's going to be really big for this inflammation hypothesis. There'll be a number of trials looking at, can computer decision support help improve care? We're seeing more and more of this with EHRs and reminders, and there are a number of studies on that. There's also going to be a huge study in electrophysiology. So Philip Kuchlik and his colleagues at Washington University in St. Louis have already published a very small series of 5 patients in the New England Journal in which they do non-invasive ablation. I know that sounds crazy because ablation is invasive, but this is using XRT therapy, radiation beam therapy, to ablate areas of scar-related VT. The initial report of 5 patients looked really good, and the Encore VT study will be presented at AHA, and that'll include up to 20 patients where they're ablating scar-related VT. My friends, this is a potential paradigm changer in electrophysiology, because imagine if we can map the VT non-invasively with a vest and then deliver XRT without putting any catheters in the patient or using anesthesia. It's a huge deal. Finally, I think another big topic of discussion at AHA will be the release of 2 sets of guidelines, first on exercise and second on an update to the cholesterol guidelines. And the cholesterol guidelines are going to be huge because, of course, they're going to incorporate PCSK9 inhibitor use. I'm looking for one specific thing, and this is going to be the dualities of interest that the ACC and AHA have. And these two interests are squaring their strong policy statements on equitable access to affordable care, and then on the other side, their endorsement of use of the PCSK9 inhibitors that are, even at reduced prices, super expensive and arguably very low-value care for most patients. So that's it for this week in cardiology. I'm grateful that you listened. Again, if you like this podcast, please consider subscribing, giving us a 5-star review. That would be great. I'm looking forward to going to Chicago for AHA. I hope to see many of my clinical colleagues, and I'm looking forward to seeing my Heart.org Medscape Cardiology colleagues as well. See you then.
You're listening to This Week in Cardiology from the Heart.org on Medscape.